Hello everyone, this is Wijdan Omer and I will be presenting a review and critique of cost-utility analysis paper. The study I've chosen is cost-utility analysis of deep learning and trained human graders for diabetic retinopathy screening in a nationwide program. The study was based in Thailand and published in 2023. It basically compares AI deep learning versus trained human graders for diabetic retinopathy grading of color fundus photographs, CFP. It was done in Thailand, which is a middle-income country, in 700 primary healthcare units. They screened non-referred Thai patients who are 40 years and older with type 2 diabetes mellitus. The objective of the study is to prevent sight-threatening diabetic retinopathy in diabetic patients, improve compliance, and mitigate shortage in human graders. The time horizon was over lifetime with a 3% discount rate. Methodology was cost-utility analysis using a Markov model with an embedded decision tree. The result showed that deep learning was associated with a reduction in cost of $2.7 per patient. The quality was about 0.0043. Although both ICERs of human graders and deep learners were dominant, the deep learner incremental net monetary benefit was $771.5. Deep learning had higher sensitivity, 0.95 for DL versus 0.737 for HG. That means these are the true positives. It had slightly lower specificity, which is 0.98 versus 0.986 for HG. And this is for the true negatives. The conclusion was that the paper proposed deployment of DL for diabetic retinopathy screening. So what is diabetic retinopathy? It's a global leading cause of blindness. It affects 1 out of 3 persons with diabetes mellitus. Those with type 1 are more vulnerable than those with type 2. It occurs when high blood sugar damages the tiny blood vessels in the retina. The retina is this part of the eye. It's in the back part of the eyeball. And it contains the optic nerve, small capillaries supplying photosensitive cells that actually take the sensory input from the pictures that we see and conveys them to the brain. So the paper basically categorized the patients into 2 groups, those with sight-threatening diabetic retinopathy and those with non-sight-threatening diabetic retinopathy. The sight-threatenings are patients with either eye having diabetic macular edema. The macular edema occurs when those damaged capillaries or small blood vessels start to leak fluid and fat into the retina and obliterating some of those photosensitive cells, which impede or produce abnormal vision. Severe non-proliferative diabetic retinopathy is just the maximum amount of leakage that can happen from those damaged cells. They can also produce aneurysms, which are balloon-like structures. And then when those are damaged, the eye starts to there's growth of abnormal blood vessels, and this is called proliferative DR. And this is when it becomes very severe and almost about to cause retinal detachment or blindness. So this is the visualization of those stages. In the mild form or normal eye vision, you can see that there's only 5% risk of progression to STDR. As we go from mild to moderate to severe non-proliferative diabetic retinopathy, the vision becomes blurred. We can even start to experience those floaters or floating blind spots. This occurs mostly in the proliferative stage when the abnormal blood vessel starts to grow, leading to bleeding and detachment of the retina, which causes blindness. So in the study, they compared the trained human graders versus the AI deep learning. Those human graders are not ophthalmologists. They're actually healthcare personnel who are non-physicians. The results can take time, all the way up to 2 weeks delay, and it actually costs more than the deep learning AI. Now, deep learning is automated. It's completely automated. It doesn't need any human intervention. The computer takes on the colored fundal pictures, and then those get processed through multiple layer filters. And then the classification of the disease progression and severity is the output we get from the device. And of course, the results are immediate. There is no delay. So the methods of the study use two modeling techniques, or decision tree and Markov. The decision tree basically maps the screening options. Eligible patients are either those who came back from a previous year or those who started screening for the first time, but both are not referrals. If they are positive, true positives, then they're referred to subspecialties for follow-up. Any follow-up is a subspecialty. The follow-up then confirms. If true, then he exits the screening because this is a confirmed diagnosis. If it's a false positive, then goes back to screening. The same goes here. And then the exits are basically for ungradable or referred or those who die. The Markov model shows the progression of disease. If there's no, there's a probability that a person can progress into severe threatening or not progress, and eventually the two can also progress to bilateral blindness or death. Now, economic evaluations. The study accounted for all the direct and indirect costs of treatments, as well as utilities. It was taken from two perspectives: the societal perspectives and the provider perspectives. The reason why the societal perspective had higher costs because they accounted for treatment for rehab after the bilateral blindness in the long term. But from the provider point of view, it's just the treatment period. It's not the lifetime rehab extended cost. In both, we can see that human graders cost more than deep learner, but for the provider, actually the human graders cost less than the treatment cost is less than the provider's perspective. It is, of course, compared against the social willingness to pay threshold of Thailand, which is about $4,997 per kali. And it turned out that the lifetime cost is a substantial portion. This is the yellow part here, is a substantial portion of the overall cost. So from the provider point of view, it's not that cost effective. Here's the cost utility analysis. We can see here that the deep learning is dominant, and the incremental net monetary benefit is about 771 from the societal perspective. This is the cost effectiveness plane. We can see here the blue dots are the DL or deep learning. The yellows are the HG. The HG are, if you consider that this is the threshold, the yellows are more above the thresholds than the DL. This is a one-way sensitivity analysis to confirm the accurateness of the study. And the study concluded that DL is actually in middle income countries is as effective as a high income country. We know that in the United States, it was confirmed as cost effective with high utility. And in 2018, the FDA actually approved it and it was deployed into the system. It was one of the rare AI innovations that are actually deployed. So this study is proposing that it provides an economic rationale to expand DL-based DR screening in middle-income countries as an alternative for limited availability of skilled human resources, which is a big problem there in Thailand, and because they have also high prevalence of diabetes in their population and low compliance. The strength of the study is that it actually fulfilled CHEER standard of reporting. It used international clinical classification of diabetic retinopathy. That means it's generalizable and replicable. It extended through a lifetime horizon, and it included the costs of treatment of DME, which is it has the highest cost burden. And this has been rarely considered in relevant publications, so it's good to see it here. However, the weakness is that the study excluded type 1 diabetes mellitus, which is it accounts for more diabetic retinopathy rates than the type 2. Okay, thank you for listening, and that's all. Thank you.